Next up is invasive line procedures in the transport environment. We will cover one of the most hands-on, high-stakes topics in critical care transport. Um, and this lecture should be a little shorter than previous ones. Um, but think about whether you're picking up a patient from a community emergency department or from a large ICU. Um, they'll often arrive with some combination of arterial lines, central venous catheters, PICC lines, dialysis catheters, ports, or other specialty lines like Swan-Ganz catheters or ECMO cannulas. Um, Although your job isn't always to place them, you absolutely must understand what every line does, how to keep it safe, and how to troubleshoot it when something goes wrong, either on a bumpy road or at 3,000 feet. So let's get started. Learning objectives for this lesson are pretty straightforward, but they're critical. By the end of the lecture, I'd like each of you to be able to walk up to a transport patient, identify every line they have, know what each one is for, understand the waveforms or the readings that it produces, and have a clear plan if something goes wrong. I also want you to be comfortable pulling the right information out of those lines to support your hemodynamic decisions. Um, these aren't abstract concepts at all. You'll use every single one of these skills on patients going forward. Let me walk you through the big six categories of invasive lines that you'll encounter. So arterial lines, central venous catheters, PICC lines, dialysis catheters, implanted ports, and other specialty lines like pulmonary artery catheters or Swan-Ganz catheters, ECMO cannulas, IABP sheaths, and things like that. Um, Arterial lines, to start, those give you a beat-to-beat blood pressure and easy access for arterial blood gases. Um, they're also your best tool for titrating vasopressors. Central venous catheters, CVCs, those give you central access for pressors, for volume infusions, and for CVP monitoring. PICC lines, those are the long haul access devices. They're great for giving antibiotics and TPN, but they need careful handling to protect the arm and to prevent kinking. Um, Dialysis catheters, those are high flow specialized devices. Um, we don't typically use them for general medication access unless specifically ordered. Implanted ports, those are accessed with a Huber needle and require sterile technique. Um, and then you've got specialty lines like PA catheters, pulmonary artery catheters, ECMO cannulas, and IABP sheaths. Always follow the hospital's protocols. Um, don't reposition anything, just protect them. Going back up to the arterial lines, so your art lines. Um, Locations for those could be radial, they can be femoral, brachial, they can be in the dorsalis pedis. Um, and the priorities for you for transport are to level and zero at the phlebostatic axis. Um, Look at the waveform quality, securement, backup NIBP, things like that. Your central venous catheter, those are typically placed in the internal jugular vein or the subclavian vein or even in the femoral vein with the triple lumen. Those are great for giving vasopressor or inotrope infusions, obviously for CVP monitoring, and also for difficult access patients. Priorities for CVCs are confirming that they're secure and that they are patent. Um, Preventing air emboli is a huge thing to look out for, and tracking which lumen infuses which medication. Tracing lines, always important. PICC lines, um, those are usually in the basilic or the brachial or the cephalic veins to the SVC. Primary use, long-term access for vasoactive meds, antibiotics, TPN, things like that. Um, in route, when you have somebody who has a PICC line, always avoid doing blood pressures on the affected arm. Ensure that there's clear labeling and always keep the line patent, protected from kinking during repositioning and things like that. Dialysis catheters are typically inserted into the internal jugular or the femoral. Um, those are tunneled cuffed catheters. Um, as dialysis catheters, they're obviously used for renal replacement therapy, but they're also high flow access for CRRT. Um, and then your role for transport should be confirming whether the catheter is in use. It may not be. Do not use that for routine meds unless you're ordered to, and always protect it and every other line from contamination at all costs. All right, so let's dive into each one of these a little deeper. Arterial lines, we'll start with those. Um, Art lines are one of the most important monitoring tools in transport if you have one available. The radial artery should be your first choice. It's easy to access, it's well collateralized, and it's low risk. When you look at the waveform, you should see a sharp systolic upstroke, a clear dicrotic notch marking the aortic valve closure, and a smooth diastolic runoff. Okay, that waveform tells you that the line is working correctly and that the hemodynamic readings are reliable. If the waveform on the art line looks blunted or dampened, if there's like a slurred upstroke, if there's no dicrotic notch, then you should suspect that there is something wrong with the system. Um, it could be a clot, it could be a kink, it could be air in the tubing, it could be a loose connection. Never make a major treatment decision based on a bad waveform without backing it up, without verifying with a blood pressure cuff. Art line leveling and zeroing. Um, Leveling and zeroing are one of those skills that seem simple but causes more errors than almost anything else in hemodynamic monitoring. The transducer for the art line must sit at the phlebostatic axis, which is the fourth intercostal space at the mid-axillary line, because that's the level of the left atrium. Every inch that the transducer drifts below that point adds about 2 millimeters of mercury of false elevation to your readings. So every position change on the stretcher, every time you load the patient, every time you take off and land, always recheck that level. Always zero it before departure, re-zero it whenever you make any major altitude change in flight, and always have a backup blood pressure cuff running, because if your waveform or numbers don't match the clinical picture, use the actual blood pressure cuff as your reality check. Moving on to CVP. So CVP, or central venous pressure, that is a very commonly misunderstood parameter. And I want to be clear on how to use it in transport. So CVP reflects the pressure in the thoracic vena cava and the right atrium, essentially right ventricular preload. The normal range is roughly 2 to 8 millimeters of mercury, but that number by itself doesn't really mean anything. What matters is the trend and the context. If your patient has a rising CVP, a falling blood pressure, and a worsening oxygenation, then you should think right ventricular failure or cardiac tamponade or even a massive pulmonary embolism. If the CVP is very low with hypotension and tachycardia, think volume. But you need to factor in the PEEP if they're on positive pressure ventilation on a vent, factor in the ventilator settings, because those can artificially elevate the CVP. CVP should be used as just one piece of the puzzle alongside the MAP, the mean arterial I can't say that word mean arterial pressure, uh, lactate, mental status, and urine output. Here's another fun table for you. This is line-related complications, how to recognize and what to do when you have one. Um, this table could be something that you can print out and kind of use anytime you have a patient with invasive lines, if you want. Um, so let's start with the top. Bleeding and dislodgement. Those are the most visible, regardless of line. If you've got blood at the site, if you've got a soaked dressing, if there's a line that's migrating out, your first reaction should be direct pressure and then line security, making sure that that line is secure. Um, air embolism. Air emboli are subtle and frankly they're terrifying. With an air embolism, you've got the clinical assessment is a really sudden dyspnea, chest pain, and hypotension after you kind of manipulate the line a little bit. If you ever suspect an air embolism, clamp that line right away. Clamp it immediately, and then position the patient left lateral decubitus with Trendelenburg if at all possible. And then push 100% oxygen and call the receiving team and tell them what's going on. Anytime a patient has an invasive line, they are at a very increased risk for infection or in worst cases sepsis. Infection is not something that you can fix in transport, but you should always document it and always communicate it with the receiving providers. Never remove a critical line while en route unless it's actually life threatening. And if you have to, always maintain aseptic or aseptic handling and always have a direct line with the receiving team at the hospital you're going uh, to so that they know what they're getting. Um, right, down to thrombosis and line occlusion. So thrombosis means stop trying to push through that lumen and use an alternative. Um, when you have a suspected thrombosis or a line occlusion, what you'll find is you'll get resistance to flushing out the med or the syringe. You'll get an inability to aspirate the contents. Oftentimes, depending on where the line is placed, you'll get some swelling in that area. Um, Anytime you have thrombosis or line occlusion, stop the infusions that are going through it. Don't force a flush. Use an alternative lumen or alternative access, and always make the call. It shouldn't ever be on you. It should not be your fault, especially if you didn't place the line. You're just the middle person who is taking the patient from point A to point B. But at the same time, um, if you're able to act and react quickly, succinctly, and effectively, then you can do a whole mess of good for your patients. And so the bottom left, an accidental intra-arterial infusion. At that point, you'll get a bright red pulsatile blood where there shouldn't be. That means stop the infusion immediately. Leave the catheter in place and call for help. Those are emergent situations that require expertise to mitigate. Whenever you have a patient, whenever you're transporting a patient that has invasive lines, um, try to make a checklist. That could really come in handy for you in route, especially when you're trying to manage multiple different areas and aspects of the patient's condition. Uh, the invasive lines should not be. Um, I mean, they're not always the primary focus, but if anything goes wrong, then they will become the primary focus. So this checklist is a pre-departure kind of ritual for every patient with invasive lines, and I encourage all of you to make it yours. Step one: identify and label every line. If it's not labeled, label it before you leave. Always. That way you can keep everything straight, and when it hits the fan, you can trace it back and make good decisions that won't harm the patient. Step two: site assessment. Inspect every insertion site. Look for bleeding, look for redness, look for swelling, look for a dressing that's not secure, and not only note that, but see if those things can be addressed prior to transport, if at all possible. That'll lessen your burden a ton. Step three: make sure that every line is taped down and anchored to the patient and the stretcher with no tension. Um, that's really important, especially in a mobile environment. Step four: confirm that the monitoring is set up correctly. Make sure that the waveforms are visible, that the transducers are leveled and zeroed, and that the alarms are set. The alarm should always be set according to protocol for the hospital that you're both taking them from and delivering them to. Step 5, redundancy. Have a backup plan. Um, Always have a backup plan. Have a blood pressure cuff ready. Have at least one peripheral IV if you can get it. And have a contingency for any line that might fail. Step 6 is documentation and handover. Always document everything and give a thorough handover to the receiving team. The This checklist itself should take you less than 5 minutes to kind of run through for each line, and it can really prevent catastrophic errors. All right, let's wrap this one up with some key takeaways for invasive line procedures and transport. Here are the core principles from this shorter, more abbreviated type of lecture. Um, every invasive line gives you the capability, and it also adds risk. Never accept one without understanding both sides of that equation. All right. Arterial lines are only good as the waveform and the leveling. If either is off, then your numbers are going to be misleading. So make sure that you're diligent about leveling and zeroing those art lines before transport, so that you are confident that the readings that you get during the transport are going to be accurate. Your central line, your CVP, that always tells you something, but it never tells you everything. Always just use it as a trend in context, never as a isolated thing. The best time to prevent complications is before leaving the sending facility. Make sure that everything is secure. Make sure that everything is labeled. Always inspect each site for anything that looks awry, and then verify this. Verifying the systems can take just a couple of minutes, and they can prevent disasters that'll take hours to manage, and really cause you a lot of grief during the transport. And then finally, when you hand off the patient, always communicate everything: what lines are in, what's running through each one, and anything you observed during the transport. The communication itself is actual patient safety. You're doing what's right by your patient just by being thorough. No, um, we're not physicians. We don't have to know everything about these lines and what they do, and I mean, most physicians don't even know that. But if you at least are prepared and you have a plan and you're consistent with that type of plan across all of the patients that you transport that have invasive lines, um, it makes it a lot less intimidating, and it can really help to ease anxiety for you. Um, just having a general idea and understanding of what they are, what they're used for, where they should be located, and how they should look, both physically, at the site, and if there's monitoring to accompany it. And if you're able to have a systematic approach for those invasive lines that can not only alleviate stress for you, but it can also help you to be able to focus on other possibly more important things during transport, and not have to worry about um, the intimidating lines that are in.